Good afternoon, everyone. It's Michele Calabro here speaking. I'm policy advisor at the European Patients Forum, and today I will be the moderator of this session. To begin with, we'll have a few housekeeping rules just to make your experience today a little bit more smooth and as straightforward as possible. Many of you joined already the first two issues of this webinar series on digital health, so I'm sure that you're already familiar with, but as you can see in the slide that you have in front of you now, you can minimize the control panel. You will be all on mute mode in order also to allow as much as possible a good connection from the side of our speakers. If you have any questions, of course, I know that some of you already sent something before the meeting, but if you have any question, you have the question panel that you can use. We will be able to see your question, and we will, of course, try to collect as many as possible, especially at the end of this meeting and following the two presentations from Deepak and Virginie, where we'll have a Q&A session with your inputs, and we hope that we'll be able to cover again as much as possible from your question. Just a couple of words again on the webinar series itself. We're trying really to build the knowledge of all our members on the topic of digital health, which is clearly one of the let's say one of the main topics that have been discussed and have been like at the priorities level from the European Commission side and in Europe in general. And clearly with the COVID crisis emerge even more as something that it's really in our life every day and in relation with our health system and services. So today, actually, this is the third issue of this webinar series. The first two are available online, as this will be as well, together with the materials. And today we will look at the topic of health data sharing, which is clearly something particularly important for patients in Europe and beyond. And we'll try, with the usual style, to clarify a little bit the basic of data sharing, the importance of data sharing for patients, pros and cons, and then we will look at the experience of one of the EPF members, EURORDIS, with a dedicated research on health data sharing. So I will not, I think I covered everything that I had to cover for this first introduction. So now is the time to give the floor to our first speakers. The first speaker is Professor Deepak Karla. Is president of the European Institute for Innovation to Health Data. He plays a leading international role in many research and development projects, especially on electronic health records. He is also professor of health informatics at the University College of London, and he'll be telling us a little bit more about health data needs for clinical research and its importance, also in connection to one of the projects that actually we're working on together with Deepak, Data Saves Lives. So Deepak, the floor is yours for your presentation.
Okay, Michele, thank you very much. So I'm just going to start my webcam for a few seconds, just so you know what I look like. As Michele kindly said, my name is Deepak, and I'm heading up this not-for-profit institute. We've had a long history of working across stakeholders to really help everybody to get better benefits from health data, but importantly, to do that in very trustworthy ways. I'll give this presentation now, and I'll just turn off my camera so that we preserve the bandwidth, but now at least you know what I look like. Good, so thanks very much. Now, oh, I do have the control, which is rather nice. Great. So I'd like you to imagine for a moment that a patient has been newly diagnosed with a raised blood pressure. They've got no other complications. Their blood pressure has been found to be high, and their doctor is going to want to treat that blood pressure. The blood pressure itself is not especially the danger issue. It is that raised blood pressure puts pressure on a lot of organs in the body, and gives you a higher risk of heart disease, of stroke, kidney disease, and other things. So the control of blood pressure is important to prevent complications. That's its job. There are choices. So what choice would a doctor have? There are 3 classes of drug. Each of them have many different specific drugs, but there are 3 different families of blood pressure treatment that could be chosen for a patient starting from scratch. And we know that in clinical practice across the globe, all 3 families of drugs are used very widely. There's not a single front runner. But the problem is we don't have the evidence, or we didn't have the evidence of which one of those is most likely to achieve that treatment objective, which is to prevent or reduce the risk of somebody having a complication from high blood pressure. Now, why is it difficult to do that? Because all of the drugs do have some protective benefit. It's not that any of the drugs is useless. The difference between these drug categories is quite small, so it's quite hard to measure it. And it takes time to measure it because the complications may come many, many years after the first rising of the blood pressure. That means that in order to study a small difference in a delayed complication, it takes a long and complicated clinical studies. That's made it prohibitively difficult up to now to undertake this kind of research. However, the good news is that just a few months ago, a breakthrough paper was published that gave that important factual answer to the question, which of these is the most effective and safest first treatment for a brand new patient with raised blood pressure. They looked at these 3 classes of drug, and they eventually found, through looking at the data, that there is definitely one that has a benefit above the other categories. This was the first time that any substantial evidence has ever been found of which of those 3 classes is the best one to choose for an uncomplicated blood pressure treatment. Now, why was it possible to do this research when I said it's actually so difficult to achieve it? They were able to look at 4.9 million records of patients who had a high blood pressure. That's not a population of 4.9 million, that's 4.9 high blood pressure treated patients. They looked at 9 big databases in a number of countries across the world. They could look back at the historic story of these patients over several years, and they could look at many, many different disease and treatment facts in order to identify what the differences were. If you just look at the volume of data they looked at, the number of patients, it would have taken 22,000 ordinary clinical trials to generate that much data. And it would have taken many years because it takes years for these complications to surface. But they were able to do it in months at a relatively low cost. And they did that because they were able to look at multiple databases at once. It's the power of health data. But that's not the only example that we can find to show how big data can make a difference. In a study that looked at 700 million patient records, they were able to identify new risks, new predictors of cancer risk. These can be very useful in healthcare because they can allow an individual clinician to identify which patients should have maybe more intensive screening or more frequent screening. So it can make a real difference to how healthcare is delivered. Another study looked at large numbers of patients with cardiac disease and found 200 different things that could be looked at in the blood, in the genes, that could help give better prevention to cardiac complications. Another study looked at 8,000 patients who had leukemia and found that actually the elderly were not treated optimally sometimes because they were considered to be less likely to benefit from treatment. And they found the evidence that showed how it is important and of benefit to treat much older patients than were classically treated for leukemia. And then another study looked at all of the prescriptions in a country given for a certain family of respiratory disease in order to look and see whether clinicians are following best practice guidelines in how they treat those respiratory diseases. And where they are not following the best guidelines, there's an opportunity here for better education, better support to clinicians, so they're always using the best recommended treatment for their patients. Those are just examples of learning, but what about the difference that can make to patients? I want you to look at the 4 facts on this slide. This is not about using knowledge from data to publish academic papers or to have nice nuances of facts. This is about saving lives. This is about showing how using knowledge from data to change the way you deliver care in a hospital, in a primary care general practice environment, or in a multi-professional setting, you can transform the lives of individuals, prevent people from dying in really substantial ways. So I hope that this wakes you up and makes you realize that looking at data is not a pastime. It's a life-saving, life-changing opportunity that we don't do enough of. If we look at examples of companies who can make use of health data, a pharmaceutical company can use data to help identify a cancer that's proving very difficult to treat, doesn't have very good outcomes, and identify a potential new drug that could help treat that cancer more effectively and better. An example again of where it's probable such a drug would save lives. An infusion pump that is computer controlled could deliver a medication continuously to somebody who is perhaps got a very brittle, severe long-term illness, but it would allow them to continue at home or at work, leading a normal life because their medicine is being carefully titrated against their needs, maybe hour by hour, maybe even minute by minute. That's a medical device manufacturer conducting innovative research through data. Or a smart monitoring system that gives a patient an alert when a reading, for example, their blood pressure, or it could be a blood sugar measurement, has been detected by the device and needs urgent attention. This could be urgent attention that the patient isn't aware of. It's not yet triggering a symptom, but if it's nipped in the bud, if it's dealt with quickly, it can prevent the patient deteriorating. This is a health software company example, but these are examples of where companies, as well as health systems, benefit from having access to data and making use of data. Have we solved all our problems? Are we now at the stage where we know what we need to know? We're not at that stage. And this is a chart. I don't need you to understand and look at the detail. What I want you to look at is that each of those 3 columns has orange bars that are not the same length. What that means is the life experience, the illness and death experience of patients with heart failure in different countries is different. In some cases, you may notice the countries are not in the same order. That means some countries are getting certain aspects of heart failure care right, and other aspects of care they're not getting as right as their neighbors. It's an opportunity for countries to learn from each other. What are you doing in your health system that we're not doing that means your survival rate is better, or patients, when they're discharged, are not having to be readmitted quickly afterwards because they've slipped back very quickly into a deteriorated state? Learning from each other, that's only possible through looking at data, sharing knowledge from data, collaborating. And that's how health systems have to be. That's how we all have to be, really learning. It's getting more urgent. Why is it getting more urgent? Actually, because we're all getting older. And as we get older, we collect more and more diseases. The first disease doesn't kill us, so we get the second disease and the third disease. And it's actually at the stage now where we're projecting a very substantial increase in the number of people who might have 4 or more diseases. The trouble is, most of our scientific evidence today has come from clinical studies on single diseases. And we are really struggling to have enough knowledge about how diseases interact, treatments interact, and what is the best treatment for disease B when you have disease A. It can be different from the treatment that you'd have if you didn't have disease A. So we need to learn all of that by looking at the data. There are many kinds of questions we need to be able to answer from the data. How diseases and treatments interact, which I've just said, which treatments give the best results, which was the blood pressure example I gave you earlier, but also how safe is a brand new medicine? It may have had clinical trials, a few hundred patients, a few thousand patients, but when it's out in the world and maybe tens of thousands of patients have built up experience of it, we can really understand what the side effects are. Who should we screen for diseases? I mentioned before that if we can determine predictors of disease, we know who to screen more intensively and who can have a light touch screening. And as you all know, we are struggling worldwide to understand COVID-19 better. How are new viruses like that transmitted, treated? Who gets the complications? Who responds to which treatment? There is now a global battle to understand as much as we can and share as much as we can. We need everybody, the companies that are trying to make vaccines, the companies that are trying to make test kits, the public health services that are trying to work out the best restrictions and lockdown measures. We all need business intelligence on this virus and how it's affecting us. So this is really our desperate need to learn more from data. What data am I talking about here? We think classically of electronic health records, the data that clinicians enter when you see them, doctors, nurses, physios, dietitians, others who will enter data. But there are other kinds of data. There are population health registers that already collect data on the whole country about certain things. If you've had a certain operation, if you've had a certain disease, the summary of that goes into a national database. Our genetic profile is proving increasingly important to help understand who gets which disease, who responds best to which treatment. There are sensors and wearables that people also can have, they use, whether for wellness or illness, that provide us valuable insights into the individual, because they're not capturing data every 3 months when you go and see a clinician in a clinic. They're capturing data on you multiple times a day. That's a very rich, thorough picture of you that is helpful when we're trying to understand how a disease is operating, how it fluctuates, what are the early warning signs of a deterioration, for example. And then there are other non-health things, climate, pollution, transport, that do impact on our health. And we can start to link health data with other kinds of data and learn even more, which is a fascinating opportunity that we're just beginning to take advantage of. I'd like you also not to forget about the fact that we are looking increasingly at healthcare being handled by individuals. So this is an example of a colleague of mine who has diabetes, and he's smiling because he looks forward to having a lifestyle where he can eat and drink pretty flexibly. I don't mean he eats and drinks carelessly, but he eats and drinks flexibly because he can quickly monitor his blood sugar just by holding that little device next to his arm. And in that arm, he's got a little, on his skin, he's got a very tiny gadget that is constantly measuring his blood glucose, which he can collect as data on his little device, painlessly, effortlessly, all the time. And that allows him to quickly check what's going on and he can see whether he's in a good enough position to go ahead and eat a meal that he's about to enjoy, or whether he needs a little top up of insulin before he has that meal, which he can do with a pen that he carries in his jacket pocket. Really flexible, really easy. This is about using data at the level of the individual. And we can do the same at a bigger scale, but the important message here is don't think only about health data as the data that lives inside a hospital or a general practice, or is part of your illness. Remember, for every disease a person has, there are 99 other diseases they don't have. Maybe there are 199 diseases they don't have. So everybody is not a patient or a citizen. They're in a hybrid state of having the odd illness that they've got, the odd illness that they're preventing, and then a whole bunch of other things that they're keeping away through a healthy lifestyle. And as people, you are all collecting more and more data about that journey, about your ongoing daily life, which is hugely valuable as the industry and health systems also shift from only intervening when you're desperately ill to trying to look after wellness and prevention. We've all got to look at that whole spectrum of the human and therefore get as much data as we can to learn as much as we can about how to do that. And it's becoming easier. This is a little bit old now. The data on this slide, the numbers are not bang up to date, but what you can see is that they are huge numbers. You see, without even reading this chart properly, numbers like 17.6 billion, 6 billion, 3.4 billion, 97,000 M-Health apps, probably many more by now. The main thing is there's an explosion of opportunity for us all as citizens, as patients, to be in the data game, helping to communicate our insights into a pool along with our colleagues, along with our friends and family and other neighbors, so that we can all learn from the data. Now, if we're going to do that, we really have to consider that we need trust. The one thing that seems to cause hesitation about making data more available is trust. And that trust is needed across the board. People, the data subjects, the people about whom the data are, the patients or the healthy citizens in the public space, they need to be able to trust that their data is being looked after appropriately, that nobody is using their data to discover things about them that are a bit personal, that they don't want known, or that they're going to misuse that information. The organizations that hold the data, for example, a hospital, also needs to trust because they are acting on behalf of their patients. If they release some extracts of their data anonymously to a research organization, they need to know they're not placing their patients at risk in any way. You may like to know that the people who use the data for research actually also care. Many of them are very concerned to be good citizens when using data. They don't want to know who individuals are. They just want the set of data that they can analyze. They don't want to know who you are. They don't care who you are. They don't want to try and do anything malevolent. I've been working in interaction with all sorts of research organizations over many years and found wonderful people who are really dedicated to the human betterment, not looking to do anything malevolent with the data. This is a really busy slide, and I don't want to read all of these bullet points out. I just want you to realize from this slide that there is a huge range of public bodies, charitable organizations, companies who all have a role in using knowledge from data to deliver solutions that help improve care. Those solutions could be a better way of organizing care within a hospital, for example, a care pathway, a patient journey, see this specialist before that specialist, have this test before you have this procedure. Or it can be at the opposite end of the spectrum, a company that develops brand new algorithms that are going to use artificial intelligence to help us to detect early a risk factor or an issue or a deterioration. They're all in the spectrum. And nearly everybody in these organizations, and I will say nearly everybody, is well-intentioned and wanting to do something innovative that benefits health, benefits society, benefits us. Occasionally, of course, there are scandals, there are negatives, and I'm not wishing to pretend to you that any one of these bullet points is full of perfection. But in general, there are huge numbers of people out there wanting to do good with data if we can help them. And what we have to do is to find a way of making sure we protect the interests of the public and that we ensure that all of those actors are doing the right thing with data and that no one can do the wrong thing with data. One of the ways that we can do that is through having codes of conduct. And I found a lot of organizations are really welcoming of a code of conduct, especially if it's a code of conduct they've not designed. It's come from outside, it's imposed on them, it helps them to feel they're doing the right thing, that they are really using the data in a legal and legitimate way, they're complying with things like the data protection regulation, that the research they're doing is ethical, that it's being conducted in a suitable way, and that some independent body like an ethics committee has reviewed their research plan and made sure that it's being done in an appropriate way, that they're using the data for a purpose that has some form of approval, that they are using the data not for commercial advantage, not for marketing, not for sales. They're using it to develop something new that could be knowledge, it could be a product, it could be a service, it could be a tool, it could be technology, something that is really of value to society. And when we talk, and my institute does a lot of work on data protection, giving guidance, giving advice, I encounter that almost every organization is very keen to comply fully with our newer European regulation on data protection, which is known as the GDPR. Sometimes they have uncertainties about exactly what the right thing is to do, about how to anonymize the data in a robust way. So they can have uncertainties, but they're open to having help and guidance. And we see an increasing number of experts offering that guidance so companies behave well and appropriately. But we do have a challenge around what society will accept. Because all of our regulations around data protection and even on ethics focus on the rights of the individual to have privacy, which of course is very important, but it's very much focused on the individual. Whereas clinical research mostly doesn't bring benefits to an individual, it brings benefits to society, to a set of patients with a disease who can all benefit from some new knowledge and understanding. When one looks at surveys undertaken across patients, and we're going to hear more about this in a few minutes, in general, patients want their data to be reused for research, provided that that research is targeting something of health benefit. So scientific research, yes. Market research, no. That's very clear signal from many, many, many studies. So we have to find a balance here between how do we ensure that we can respect the privacy of individuals and yet do good with our data. And that's a challenge that myself and colleagues in my institute and many others around me are trying to work out. And one of the ways that we want to help with that process is exactly what we're doing on this webinar, helping members of the public, helping patient organizations to better understand what we want to do with data, what is useful to do with data, and also how it can be safeguarded. Today, I've not gone into safeguards in detail, anonymization, pseudonymization, encryption, blockchain. You probably know all those terms. There's lots of ways we can protect, but I haven't gone into that today. We would love to educate everybody much more so they can make informed decisions. We're not about saying don't decide, we're about saying be informed before you decide. And so I want to close with this last slide, which is to promote an initiative that we're in together jointly and delighted to be working with the European Patients Forum, and my colleague Gosde is on this call. She runs that Data Saves Lives initiative, which is a European initiative to help do exactly what I just said. How can we help everybody better understand what health data means, why it's useful, who needs to use it, how do they use it, what do they do to protect it, and then what good do they do when they can conduct research on the data. That's a story we really want to promote around, so that everybody can find their own comfort level with what they are happy with their data use, but they do that by being informed rather than doing it just on the basis of guess. So thanks very much, Michaela, for running this session. I'm through with my talk, and I think your plan was not to take questions now, but for us to go straight on to Virginie and then to take questions later.
Exactly, Deepak, and thanks a lot for this great presentation, all things about health data, and indeed you touch several key points that we're actually going to further elaborate now with the second presentation. The second presentation, as you can already see on the screen, while we also give the control of the slides to Virginie. The second presentation will be from Virginie Roxpes, the current scientific director at EURORDIS. Before joining EURORDIS, she also worked as a research infrastructure project manager. Virginie holds an MSc and a PhD in neuroscience from King's College London, and in her presentation today, she will further elaborate on a point that you actually shared, Deepak, in terms of how patients look at health data sharing, in particular introducing and elaborating on the results of a large-scale EURORDIS multi-country surveys on the topic, which got over 2,000 respondents, if I'm correct. So I think now Virginie has the control of the screen, so I will just give you the floor, Virginie.
Thank you very much, Michele, and thank you also, Deepak, for this really very interesting and comprehensive presentation. And I think you will hear also from my presentation that there are different points that definitely echo what you just said. So I'm just trying to find, here it is, the button to move. So maybe just a couple of words on EURORDIS. First, for those who don't know our organization, so we are an alliance of over 900 rare disease patient organizations from 70 countries, and our mission is to work together across borders to improve the life of the people living with a rare disease in Europe and beyond as well. So we are an organization with around 40 members of staff located in 3 main offices in Paris, Brussels, and Barcelona as well. We've existed for about 23 years now, and obviously we couldn't do the work we do without working in collaboration with the volunteers. And at the moment, it's around 440 volunteers who regularly and consistently help us achieve our objectives as well. So I just wanted to give you a little bit of background before going into the result of this large quantitative survey, as we have used in the last few years several approaches and initiatives to consult the rare disease patient community on their perspective on patient preferences and data sharing. And most of these were actually carried out in the framework of RDConnect, which was, because it's now ended, but it was an European funded project aiming to develop an integrated platform to connect data from various sources. So data from databases, various databases, patients, registries, biobanks, also clinical bioinformatics database. And we worked regularly, so for along the 6 years of the project, with the Patient Advisory Council. We had 15 patients who were working with us on the different initiatives, and we've consulted them and worked together and integrated the learnings into the activities of the project. So actually we were hands-on in each of the work package as well. So this was done obviously with a relatively small number of patients. So some people might call them patient experts, so people who have actual experience of sharing their data in national and European initiatives as well. But we're then trying to increase a little bit the pool of patient consulted, still using a qualitative approach, and by organizing different focus groups around specific issues on data sharing for international research. So from this work, really, we identified 4 important aspects of data sharing from the patient perspective. Obviously, it was around protection of privacy, securing consent as well, the need for robust governance in those data sharing initiative and project, and also the importance of communication. So the feedback on the use of the data was also very important to all the patients that we've consulted. So we then wanted to really consult the wider rare disease patient community, taking into account the specificities that are inherent to people living with a rare disease. And the goal of that project was to encourage also the researchers, the different stakeholders who are either responsible or participate in project sharing data, to encourage them to recognize the importance of understanding and taking into consideration the perspectives of rare disease patients. We also wanted to use this opportunity as a forum to really encourage discussion around best practices relating to data sharing. So following this, we then wanted to ask the wider rare disease patient community, and we did that through the Rare Barometer Voices program, which is an online survey initiative by EURORDIS, where we carry out, it depends, but maybe around 2-3 overall surveys per year on various topics that are important to rare disease patients. And that include, for example, the availability of treatments, so their perspective from different countries, from different disease groups, obviously around data protection as well as the impact that the rare disease has on the daily life, on the life of the patient, but also on the family as a unit. So actually this slide is slightly outdated. We now have 12,000 patients and family members who've registered for the program so far. And not all of them answer all the survey, but depending on their interest and their needs as well, we ask them to answer some of the survey, and they're welcome and free to do so when we're launching the survey regularly. So we did carry out this first large-scale international survey around data sharing and data protection. We did that with the help of a topic expert committee. So we designed this survey with this topic expert committee, which included people with different types of expertise, such as sociology, legal, computational biology, patient advocacy as well, ethics, and also patient-reported outcome measurement. And this questionnaire was designed to be accessible to a diverse population with a wide range of educational background. All of our survey, including that one, are translated in 23 languages. And we got just over 2,000 responses, some from patients living with a rare disease or their family members, which are more often parents, but also sometimes close relatives, all over 16 years old, obviously. And all these respondents actually represented or came from 66 different countries and represented over 600 different rare diseases. So the first and most obvious question was why share health-related data, and actually the vast majority, actually 97% of rare disease patients consulted clearly support data sharing if it's done in the interest of patients, and whether it's done to foster research on their disease, so to better understand the mechanism, the causes of their disease, to develop new treatments as well, or even to improve diagnosis, but also to improve healthcare. So, for example, to receive additional specialist advice on their care. And that is not something we did before in the context of RD Connect. It was really focused around research purposes. So we wanted to see whether that was maybe different depending on the context, and actually whether it's for research or for healthcare. Rare disease patients are clearly supportive of sharing their data. So we've just also included a couple of quotes from there. And there is also they're also supportive of data sharing if it's to improve research on disease other than theirs, so for wider scientific interest. And 95% expressed that will. And it is interesting because so compared to the general population, it seems that rare disease patients are actually more inclined to share their data. So depending on the study that you use to compare, it's between 37 to 80, so 80 being still quite large, but of the general population that declare that they would be willing to share their data. And it's definitely significantly a lot more for rare disease patients. So those are the top 3 incentives which would encourage rare disease patients to participate in a project that involves sharing of their health data or the health data of one of their family members who's affected by a rare disease. And 69% really would like to have the possibility to learn more about their disease, or also to discuss and ask questions directly with the professional who are working on the project. And they also, at 62%, actually want to be informed on the result of the project. So when asked about how much control they would like to have over the information they're willing to share, the majority want to have the possibility to have some level of control. And clearly this is not contradictory with the willingness to share, but rather illustrate the perceived risk of data sharing. Indeed, 50%, so half of the respondents are concerned that their information could be shared with third parties without their consent, or also that it could be shared in a different context to the one that they actually agreed to share their data in the first place. They're also slightly less, but still 35% are concerned that the information could be used without their knowledge. And interestingly, 34% are also concerned that they could become the victim of discrimination. And there is here also a clear difference with the general population, as only 5% of the general population view becoming a victim of discrimination as a risk or potential concern. And that's really mostly because being the victim of discrimination, it's something that many rare disease patients have experienced in the past, whether it's so at school, at work, so in their employment, or with their friends as well, or in society in the wider sense as well. So trust, as we know, and Deepak also insisted quite heavily on that, is very important, and rare disease patients obviously expressed that trust is important, and also they expressed that they have a higher level of confidence in stakeholders who come from not-for-profit organizations. So those could be medical doctors, researchers, patient organizations, as well as other healthcare professionals. Not so much in government, which is interesting as well, as only 48% actually reported confidence in the government entities, and those are actually quite often the ones that initiate or are the custodians of the data sharing initiative. Regarding sharing with so commercial companies, it's less than 50% actually have confidence in companies, in genetic testing companies or pharma companies, and even less so in insurance companies. So when I ask also whether they would actually allow an ethics committee to decide on their behalf what to share with whom and for what purpose, opinions were a bit more divided, and only half of them were in favor. So also the survey highlighted the importance of communication and transparency and feeding back some information resulting from the sharing of health data. And even if the respondents are actually happy to receive information by email or by simply consulting a website whenever they wish to do so, they still really would like to have the opportunity to discuss face-to-face with the professional involved in the project. So we were also a bit surprised that only 56% would like to receive communication through a mobile app. We thought that would be much higher than that, but it wasn't the case. So based on those results, and I've only described some, so not all of them, but you can then find everything in the paper, and I'll show it on my last slide as well. So based on the result of this survey, we wanted to develop recommendation. So for different stakeholders who are involved in data sharing initiative, whether they initiate the project themselves or are simply contributing or participating in it. And the first one is directed at policymakers, asking them to ensure that there are appropriate legislation, both at European but also national level in place, and to foster the different type of changes that are needed to really develop international data sharing initiative in health and research for rare diseases. Then we also wanted to highlight the importance of the governing structure, and that they should include trusted representative. So it doesn't mean that it should be only, for example, healthcare professional involved or only representative from patient organization, but that you should have all the different actors representing in those governing structure in order to really provide trust and transparency in terms of how the decisions are being taken. So those also need to develop and implement robust standards to ensure secure, ethical, and responsible data sharing, whilst putting into place safeguards, obviously around data protection, and to include the different type of representative that are from the trusted organization, as mentioned by the respondents to the survey. It would be also interesting to try and promote dynamic systems, as this would really enable the possibility to express and take into consideration the different attitudes and preferences towards data sharing. It could also enable access to updated information on the research outcome, so that would increase patient participation in research and also stimulate data sharing whilst respecting patient preferences. So the different stakeholders involved in those initiatives should also ensure that appropriate resources are allocated, so at national and regional level, so in people's own languages, to develop and facilitate access to relevant educational resources to enable informed choices for the patients to share or not to share their health-related data. And I think that's also a point on which Deepak insisted on earlier on. So to really provide education and information so that people can make informed choices on whether to participate or to share their data or not to share. There's also a need to dedicate finance to educational resources, so we mentioned that, but also to improve the communication and increase the transparency on the purpose and the outcomes of data sharing. And that will also increase the participation of rare disease patients to share their data. We also need to really emphasize the potential health benefits of studies. I think it's clear from rare disease patient perspective anyway, that when they participate, especially in a research project, it's highly unlikely, if not impossible, that the outcome of the result will benefit them directly. But we need to really emphasize that it's a long game, really long waiting game, but that ultimately the result will inform better diagnosis, better treatment, better care for future generation, also for other disease area, and that could be also an incentive for wider participation. So I think that was my last slide. Yes, and this is so we published the result of the survey together with the recommendation a article, a peer-reviewed article, which is actually open access. So you can download the full article on internet just by putting share and protect our health data in Google or in PubMed. We also developed an infographic which kind of summarize and provide an easy way to present the different key results and recommendation as well. And you can also download this from the EURORDIS website. So with that, I just would like to thank all the Rare Barometer partners and also thank you for your attention. Thank you.
Thanks a lot, Virginie, for the great presentation. Indeed, well, congratulations first of all for the great survey. I think it gives a lot of food for thought and in general answers to this question of how patients want to be engaged and what they need to be more engaged in terms of health data. In the meantime, for information for all participants, I shared the link to the article in the chat, so you feel free to check it there. But we will also share all the materials together with the survey, the infographic in our follow-up on our website. Now, well, thanks again to both Deepak and Virginie for the presentation. It's 5 minutes to 3, so I think we can now open the question and answer moment of the day. We already have some good time for that. We might not finish at 3:30, but we might finish a little bit early. But I will really try to collect as much as possible some questions from the audience. If we have already something, otherwise I can also actually start with a very generic question from my side to both of you. So I'm just trying to check if there is any question being shared through our GoToWebinar system, but so far nothing yet. So actually, I would like to maybe ask a quick question to both of you. As you know, and as also EPF engaged with the creation of a European data space is something that the Commission has put as priority for the work of the new commissioner, Stella Kyriakides. Therefore, I think it's going to be, let's say, an exciting time, especially during this post-COVID, let's say, recovery part on this topic. Might be a €1 million question, but I would like to ask to both of you, and maybe we can start from Deepak. What are, in your views, the 3 key elements that you would like to see in the European health data space? What are the 3 key things that you think could help patients across Europe to be more engaged in a better and safer way with health data sharing?
Okay, that's a tough question to give me three magic.
You can do more.
Well, no, it's probably even hard to do just 3. I mean, it's either 20 or it's none. But let me do 3. I think the first one is there has to be the right data in there. So it's really important that as a European entity, the European health data space is open-minded and inclusive about the different kinds of data that might exist around Europe that are possible inclusions in the data space. Now, when I say inclusions, I don't necessarily mean copy and paste into a giant bucket of data, because we have nowadays modern technologies that mean that you link to data rather than have it. So it's about connecting rather than containing. But still, it's important that we have a range of data. Why do I say that? Because if the data is going to be used to make new insights, new discoveries that inform health policy, health strategy, companies, products, services, it's important the data reflects Europe. If you go for, let's say, easy data sets, sometimes you end up with data that is biased. And it's great that this is a webinar with Virginie as my colleague, because you know, on the one side, there are rare disease networks and European reference networks that are sources of data that are being discussed within the European health data space. But there's a risk that if other types of data are prioritized, patients with rare disease will be invisible. And that would be terrible, because we need a balance of who is reflected inside the space. The second point I'd like to make is that we have to make sure that the rules about how the data come in, how the data are held, who is allowed to look after the data and make decisions about who can access it, and then who does access the data and why and what beneficial purpose, are all openly shared, openly discussed before they're defined, that all of those stakeholders, especially the ones on Virginie's slide about who should be involved in decision making, are really involved in asserting their view about the right and moral and proper way to use the data. And the third point is that we need to have enough actors of different kinds able to use the data so we really get rich benefits. That's my three.
Thanks a lot, Deepak. And maybe you'll have the chance to give more afterwards. I'll now go to Virginie. From EURORDIS perspective, what are your let's say your key views, also building on the survey that you had? You have some set of recommendations, but if you'd like to see, let's say, some of them already, let's say, more urgently implemented, more urgently taken care of, what would you like to see?
Yeah, and I think that it's not really any different to what Deepak just said, but so it's around communication and transparency. So as Deepak mentioned, it's on the different actors who decide, you know, on the use and also on the outcomes of the different projects that could be using that space as well, and also around education. Sorry. So to try and also organize some kind of I don't know if capacity building program is the right term here, but it could be some webinars, what you are actually doing right now, you know, but to have that also around the development of that space, and to really ensure that you get the public and the patients on board from the start, really to explain the different aspects, the different prospects, and also obviously around the governing structure, which is again related to the transparency and the communication.
Perhaps if I could just come in and say, on the topic of the European health data space itself, I'm very fortunate to be part of a European support action project called Digital Health Europe, in which the European Patients Forum is also a partner. And so I know you through another hat of that project. We are actively involved right now in consultations around the European health data space on what might be the level of interest, the governance rules. There are a number of webinars and consultation events taking place, which are trying to address that issue. That issue meaning to listen to what our stakeholders want the space to be like and to behave like. And in fact, we are planning, in fact, immediately after this call, I have a TC with colleagues from that project. We are planning to have, probably not till October, because of holidays and things, a virtual focus group of patient organizations, of which both of you on this, you know, would be involved for sure, to explore in more detail what would be the patient and public acceptability of the space. And we're delighted that the Commission is very supportive of that. And already we've had, you know, engagement with the Commission on participating in these events and listening and learning from them. So I'd just like to plug, really, not plugging the project, but plugging the Commission and saying that it's really interested in getting this right. And I have very nice feelings at the moment from the people I engage with on the Commission side, that they really want a success that is welcomed by the public, by European citizens. And I think, Virginie, people like you and me have to help And Michaela, you with your digital working group, we've got to help. And actually, Gosde with Data Saves Lives, sorry to grab all of you, we've got to help the Commission because they want to get this right, and we probably have ways of helping them do it.
Yeah, that's great news. Yeah.
Indeed, Deepak, yeah, no, absolutely. The role that organizations like EPF can do, but also all the members, EURORDIS included, and all the other members that are here in this call, especially or participating in the Digital Health Working Group, I think they can all have a great role in coming together and really giving the support that the Commission needs to understand what's needed from the patient side to make this European health data space work. And actually,
I will just say, if you don't mind, Michaela, I hope you don't mind, but I think it's useful to just add one more point. We held an industry focus group recently as part of the project. That means we had about 25, 30 people from different industry subsectors. And what they said very clearly is that there are many, many initiatives around data sharing and data access taking place across Europe. But without doubt, the European health data space is going to be the biggest player. It's going to be bigger than everybody else's space. And what they would like is that we also see the European health data space acting as a thought leader on what is good practice. And other initiatives that are not part of that space, but are separate, would look, if they can, to copy the governance model and the approach of the European health data space so that we grow by goodwill, not through by law, but by goodwill, we grow a consistent approach across Europe. So a citizen can say to themselves, if my data is in one database, 2 databases, 10 databases across Europe being used by different players, actually there are some common rules that everybody has agreed to sign up to that give me confidence that my privacy is safe. I would love us to achieve that.
Thanks, Deepak. Indeed, I mean, I think it's going to be really important to be all together on this. And I mean, as EPF, at least, and in my role, especially as leader on the digital health work, I'll really try to work as much as possible with you, also to the projects that you mentioned, Data Saves Lives, Digital Health Europe, but also in defining the data space to do that. But actually, I do have a question that is related actually to one of the, let's say, the sources of health data, the European health records. We also had a survey recently as EPF focused on that, looking at how they can be an important source indeed of data, and there's willingness from the patient's point of view to use them more in many ways, including as a tool to better communicate with professionals. But there's I have a question here on, and this is actually confirmed by the survey results, that maybe access to electronic health records, it's still a little bit, let's say, not harmonized as much as it should be. It still has some hurdles in understanding how to access, how to eventually patient can be able to update or to amend the data that is contained in there. I wanted to get from both of you a view on, from your perspective, what could be elements of like making electronic health records a little bit more accessible and better, let's say, usable by patients.
Virginie, I've done a lot of talking. Why don't you take that one first? Because I think
I was trying to
rare
think.
diseases.
So
I thought, well, would you? I mean, I could go first if you prefer, but okay. I mean,
please no, do so, because I think from the patient's perspective or side anyway, it's as long as it's in the interest of patients, there's not really the hurdles is not from the patient's perspective. So it's more the legal aspects, the regulatory aspects as well, is to share electronic health records is is a tricky one. It's absolutely needed both to improve healthcare and obviously research as well. But how to do that, I'm not too sure where to start really. So
yeah, I think it's a difficult area, because with the assumption, the wrong assumption that has been made for probably 20, 30 years, is that patients don't have access to their electronic health records because there are barriers that prevent them. And if only the barriers could be removed, they would come running. Now, I was a general practitioner in London at the time when, in 1990, I remember it well, the government introduced a new law that allowed patients to have access to their paper records. So it was possible from 1990 onwards that any of my patients could come to me and say, I demand to see my records. And I can tell you that I stayed in that practice for another 5 years before I moved into this other field that I'm in now. And in that 5 years, I only had a couple of patients that wanted access to their record. And before 1990, when it was not a requirement, I only ever had a patient once, when I was a junior hospital doctor, want to know what was in their record. Now, I think that's because if you treat it as a curiosity, if you say you can look at your record if you want to, it's actually not very exciting. And many, many portals that a number of national health systems have set up to allow access to data don't find an overwhelming demand. Now, if you provide functions, if you said you can look at your medication record and you can use that to request a repeat prescription, totally different. Then you do want to look because you can get a value from that looking. If you said to patients you can download things, and when you go to the supermarket, you can scan the barcode of a product and it will tell you if it's dangerous for you, if you have a few diseases and a few drugs, and this product contains something that's a bit dangerous. I mean, for example, I'm not allowed to take grapefruit juice. Now, you may or may not know what the drug is I'm taking, but I'm not allowed to take grapefruit juice. It's a rather peculiar thing. The moment that you have cleverness associated with the data, if you give value to patients, I think the difference is great. Now, I will say, Virginie, from my limited experience of rare disease, and I would not even begin to enter your expertise, but I had a few patients in my career with rare disease. The families are incredibly knowledgeable. They really know a lot. They knew a lot more than me as a GP about their disease. And they were far better holders of their health record than I was, because they would know what to look for and so on. So I do think there's a huge empowerment value. And I wonder if you've encountered that in EURORDIS.
Yeah, I think, as you say, definitely very much an empowerment issue as well. But and I do believe that rare disease patients are a little bit more aware of the possibility or the potential of having access to their health data. But I don't think because obviously there are different needs, specific needs that maybe patients from more common diseases do not have. But I still don't think that it's really, even if there's a tendency for rare disease patients to be slightly more aware of that, it's still not all or the majority of rare disease patients, really, if you just look at that population specifically. And as you said, it's because they don't necessarily know the value and the benefits of accessing their data. So it is around also, and they don't even know sometimes that they can or how to do that. If it was just a matter of going to your GP, that would be fine. But in the case of rare disease patient, the GP rarely follows, you know, the specialist care that the rare disease patient is already under. So it's who to ask, what to ask, and how. And if they don't know all of those, then you know, they have to concentrate sometimes on the burden of living with a rare disease daily, which often takes precedence to benefits that they could find through their health record. So it's a problem of information and education, I think, really.
Yeah, I agree. I think, though, that there is a further issue, which is, you know, if you're a patient who's got 4 diseases and you've got some test results in the last 12 months, which you know the results because you've seen your doctor, you know what they are, and you've made a note in your own records of what they are, and you know what your medicines are, then what is there exciting in this online record? I mean, it's going to only contain the things you already know. So to me, I think what we need is not for the patient to be able to read on a screen the information they already know well, because that's really boring. I mean, what I think we need is the ability for that information to be downloadable into an app that offers us some added value, some intelligence, some smartness, some functions, some alerts, some reminders, and all that stuff. It's the magic of the app developer we're missing, really. And I think it's slowly coming. So, Michaela, you asked about access to the record. I don't think we should be looking at access. We should be looking at using the record in some way. And I think we're just about to explode that capability. It's, the next 5 years, it will be totally different.
I could not agree more with you on the use of data. I think we've had a lot of, even just I think I can speak on behalf of the rare disease patient community as a whole, that there are many different registries. So whether they're interoperable or not, that's a different stories. But there are really, not for all diseases, but many database registries where rare disease patient data sits and are not used. And what the patients want is for the data to really be used, whether it is for their own disease or for different diseases, but to improve research. They want to know that what they lived through is not going to be wasted, that also all their hospital appointment, tests, investigation, anything that could be in a registry or in a health record is actually going to be used for the benefit of society, of health and research and society as a whole. And at the moment, we're not making use enough of those data, nowhere near enough.
Thanks. Actually, it's great to also have this exchange, because indeed we're touching a lot of points that are very, very central to also what we should actually look at. But in the meantime, I'm also mindful of the fact that we receive a couple of questions from the audience on top of the one that I already shared. One which I think would be also nice to get both your answers comes from a member from Jana, a member of our EPF youth group. The question is, how can patient organizations stimulate patients to agree on data sharing? Are there any recommendations? I think it's in terms of really how to create consensus and the trust in terms of data sharing, and what's the role of patient organization in that? Maybe we want to start with Virginie on this.
Is it for me, because it was the role of patient organization? I think it is also duty and responsibility to explain the benefits. If you don't see and showcase some success stories of what are the benefits of those initiatives, then you'll get the incentive and you'll get a wider participation. But if it's really just abstract, it's a bit more difficult. So there's definitely a way to, and that's also sometimes, well, EURORDIS has tried to do also a mini series of webinars on different registry, different initiative from patients, from other type of stakeholders as well, to show the kind of successes that comes with sharing data and with participating in those initiatives. And I think there's nothing that says more than a success, really, because you want also to be part of it, to contribute to it, and to enable that to really benefit the wider population.
Thanks a lot. So indeed,
I would absolutely support that. The only small point I would add is that our institute has found that bringing stakeholders together is incredibly valuable. So the patient organizations are an absolutely critical success factor to us making good use of data in a trusted way. but we need those patient organizations to be in the same room, in the same conferences, when we can be in a conference all together again, hopefully not too long, alongside the pharma, the medical device sector, the regulators, and in our institute's conferences in the past, including some where the European Patients Forum has been tremendously helpful. We've either had you as speaker, or usually we've had you as speakers, we've had you as providing us with audience members from patient organizations. We've really benefited from our relationship with EPF. But what we found is that bringing together, having a speakers panel where you have 4 speakers, one of whom is a patient representative, another of them is from industry, another one from academia, whatever. The panel debates, the discussions, they really highlight the different views. The audience just loves that, because I really think it's important to learn from each other. It's not that anybody is wrong. Nobody is wrong. Everybody seems to be right, but everybody's incomplete. And by hearing about the other perspectives, I mean, the atmosphere is really electric in these situations. We should do more of that. And when we can, our institute will definitely restart having conferences. I think you can't do it well virtually. You can do it really well in person.
Yeah, I would totally agree with that, Deepak. I can't wait to go back to normal, let's say, face-to-face meeting. I think it's going to be great for everyone when that will happen. Actually, I would like to ask a last question that we just received from the audience, and again, I think we can close with this one also, because it's another $1 million question. So how about secondary use of health data? Therefore, I think it's related to what the secondary use of health data would need to look like to be a little bit maybe clearer for patients, but also in terms of trust, the role of the GDPR regulation. Maybe you want to go on the secondary use of health data first, Deepak?
Sorry, I just had a quick temporary break in audio because my headset.
Sorry.
I'm just playing around with my. It's all about battery life. Sorry about that. So I heard you reading the question. I missed your last sentence. Just apology for that.
I just tried to add a little bit of elements to the question, which is how about secondary use of health data, which I believe it's in terms of what should look like, how eventually also the European data space could clarify a little bit the secondary use of health data space itself, or any let's say recommendation from your side on this.
Sure. Well, I will be honest with everybody on the call. I don't actually really like the term secondary use, and a few of my colleagues don't, because it has that connotation of second class, inferior quality use. There's the main purpose and everything else is kind of secondary, dismissible, and so on. I don't think that a patient who attends a healthcare professional and gets treatment expects that what will happen is an exchange between what's in the mind of the patient and what's in the mind of the clinician, without any reference to what is known about their disease, about their treatment. So, for example, looking up the side effects of a drug, looking up what is the best treatment out of a choice of treatments, we're starting to enter a world in which the data on an individual is starting to be compared with data on comparable patients to say what seems to work well in other patients in that situation. So I don't believe that we compromise the value of clinical care by looking across at multiple patients. But the moment you look at multiple patients, you're kind of reusing the data rather than using the data. The primary purpose of a clinical record, and I do know this because I did a lot of research on this at the beginning of my informatics career, the primary purpose of the health record is to be the documentation by a health professional that is their accountability for what they did. The primary use is as a medical legal record of care. Well, that's not terribly useful to everybody, even it's not terribly useful to the patient. The secondary purpose of a record is to provide continuity of care, so the next person who sees the patient knows what happens to the patient the last time. And the moment you go from there all the way through to 7.9 million patient database records research, you're in a world of secondary use. Let's not call it secondary use, we can call it reuse. But really it's about the rich use of data across the whole spectrum. And I think Virginie made very important point, that a lot of the learning from the data might not benefit the individual directly, immediately. It might benefit their friends, their family, their colleagues who get the disease 5 years later than them. I've never yet met a patient who doesn't feel that they want to support the rest of society benefiting from what happened to them. So I think the issue, what we need to do is maybe challenge the use of the word secondary. It implies, I think, the wrong message about what we want to do. We want great healthcare for everybody with the best possible treatments, the best possible devices, the best care pathways, the best apps. And we do that by learning non-stop, never stopping learning from what happens.
Thanks a lot. It's a really good point. Never stopping learning. I think it's fundamental, especially in healthcare, especially in today's situation. Virginie, do you have something to add on the reuse? Let's call it like that.
I also agree. I think reuse is a much better word for it, and actually explain the potential and the benefits much better than that slightly negative connotation that secondary might have. And indeed, if it's to reuse to improve healthcare and improve understanding of diseases, then this is a part of the broader primary objective in any way. So it's reusing to further improve and further learn and understand about diseases, which we in turn will also improve therapeutic care and will be for the benefits of patients. So yeah.
Great. I don't see any additional question for today, so I think I would like to close thanking once again the great contribution from Deepak and Virginie. I think I also personally really enjoy your presentation and how you covered this particularly, let's say, interesting yet complicated topic. And I'm sure that we will get to work together even more in the future. As I mentioned before, we will share in our website on YouTube as well the recording of this meeting, the materials as well, and you can also find in the chat already the link to the EURORDIS survey. Before closing, just to remember to all of you that this is the last digital health capacity building webinar before the summer. We will get back after the summer. We'll communicate, of course, all the dates for the 2 or 3 next webinar that we might have from September onwards. We might touch things like artificial intelligence, maybe a topic that is becoming quite important as the control and ownership on data and other matters. So thanks again for joining today in this hopefully warm day of summer, and I thank everyone again for participating and for the contribution.
Thank you very much for having us.
Thank you. And it was very nice also, Virginie, to say, nice to get to know you better through this webinar. Thank you, Michaela, for bringing us together.
Thanks.
Right.
Bye-bye.
Bye-bye.
Bye.